Welcome. Today we'd like to talk about radiation safety information for low-dose medical imaging that utilizes ionizing radiation. The term safety is very subjective, and it often means absolute safety, so we rarely use it when we're talking about ionizing radiation and the risk of biological damage from ionizing radiation. Safety is subjective. A knowledge and understanding of the risk of ionizing radiation exposure is important when looking at the biological safety of utilizing ionizing radiation in medical imaging. Here we see the generation of ionizing radiation for X-ray. We have two primary types of interactions that are happening during the ionization of the atoms. One is called the photoelectric effect and the other Bremsstrahlung. We all learn this in our basic courses in radiography. Primary ionizing radiation does not change. It is merely one part of the term used overall as radiation. For in radiation, we have ionizing and non-ionizing radiation. To create medical images, we use both ionizing and non-ionizing radiation. Basically, what we are doing is recording the interaction of energy with tissue and taking that interaction and transforming it to an image that we can diagnose. We make medical imaging from all kinds of energy. We use ionizing radiation and non-ionizing radiation for a majority of the exams. The use of medical imaging is rising, and approximately 3.3 billion of the 5 billion imaging examinations performed worldwide use ionizing radiation. Thus, diagnostic imaging contributes to most of the artificial radiation exposure to human beings. What many people think of as an art in medicine is the ability to make a diagnosis. Medical imaging is a primary component of patient diagnosis. In medical imaging, we have two primary manners in which we can create medical images. One would be the photographic process, and two, the digital imaging process. We have evolved from the 1800s using the photographic process to strictly digital imaging processing today. Here we see a monument to Professor Henry L. Smith, who pioneered medical imaging uses for X-rays. Notice these studies were done in February 1896 in a nearby lab. We have evolved a lot in scientific and technical knowledge since 1896, but the basis or the primary methodology of recording imaging is using diagnostic, ionizing, and non-ionizing radiation to create the images. All images that are used for medical imaging are acquired from the recording of energy interactions with tissue. Ionizing radiation is only one form of energy that we utilize in medical imaging. It is critical to understand the type of energy being utilized, the amount of energy being utilized, and the time the energy is being utilized to create an image. We can call this the dose. When discussing ionizing radiation, we can talk about high dose and low dose. Well, what's the difference? Low dose is basically harmless and used for medical imaging. High dose actually interacts with tissue and destroys biologically the tissue. The more radiosensitive the tissue is, the better the use for ionizing radiation at high doses for therapy. Although the ionizing radiation is the same, there is a large difference between using low dose and high dose ionizing radiation. Let's take a look at creating a digital imaging. First, we have an analog signal or energy that must interact with the tissue that we are trying to analyze. The quantity and the intensity of the signal is defined by the technical factors in creating the signal. The tissue absorbs the energy from the signal. It then emits a signal that demonstrates the interaction of this process. In medical imaging, physicians utilize analog signals, or they utilize images that they can see to diagnose different types of disease and decide on different types of therapies that can be utilized in treating that disease. Visible light, or the signal that they look at, is part of the electromagnetic spectrum and is an analog signal. So let's take a look at the process from the first step to the end step. In the first step, we are going to take energy and have that energy interact with tissues of the body. That interaction is then recorded, or the intensity of the interactions are recorded. And the recording is then transformed from an analog signal to a digital signal. This digital signal is then utilized to create an image for diagnosis, selecting the data that we want to visualize. But we cannot visualize data or numbers. We have to visualize an image. So we need to change our digital data back to an analog signal, which is visible light, or the image that we look at. We use different types of energies or signals to interact with tissue to make an image for diagnosis. Most of that energy is found on what is called the electromagnetic spectrum. And on the electromagnetic spectrum, we have ionizing radiation and non-ionizing radiation. The difference being that non-ionizing radiation is of lower intensity and does not affect the tissues other than heating, whereas ionizing radiation can actually affect the cells and the DNA in the tissue, creating biological damage. Gamma radiation is used in nuclear medicine, SPECT and positron emission tomography, and molecular imaging, and this is an ionizing radiation. Sound waves are used for sonography, Doppler ultrasound, and molecular imaging. This is non-ionizing radiation. Radiofrequency signals come from magnetic resonance imaging and molecular imaging. And these, again, are non-ionization. The one portion that the public and the occupational worker is mostly aware of is X-ray, which is a portion of the ionizing radiation spectrum on the electrical medical imaging spectrum. The use of X-ray to create images can cause damage to the tissue. Does interaction with X-ray cause damage? Either gamma or X-ray Both are ionizing radiations that can cause damage. It is the dose or the amount or intensity of the signal that creates the damage. In most cases, we have no strength or energy in the diagnostic imaging range that can cause damage, whereas in the radiation therapy range, the intensity of the signal, although it's still the same ionizing radiation, is such that it can damage tissues. So we look at low dose and high dose. Low doses of ionizing radiations used for medical imaging are generally harmless. High doses of radiation used for radiation therapy are harmful to tissue. And what is the difference? The energy. Remember, when we set our exposure factors in medical imaging, we use KeV, EV being the energy or electron volt, and it's measured in thousands. When we use radiation therapy, we use MeV, or electron volts used in millions, where there is a distinct difference in the strength of the signal and the amount of damage that can be done by the signal. Time is also a factor in exposure. Well, this presentation is about radiation safety. So after getting some of the background, let's take a look at who is responsible for your occupational radiation dose that you receive. And really, there are only two people responsible for your occupational dose. That is the equipment operator, whether they're a technologist or a physician, and you. The equipment operator controls the dose or exposure, which is the amount of radiation utilized, the area of exposure, and the number of exposures required to create the data to make the medical images for study. To create medical images, we use remnant radiation. Remnant radiation is the radiation that is emitted after the patient is exposed. In remnant radiation, we have the photoelectric effect and we have scatter radiation. Scatter radiation is rather useless, and the majority of the emissions actually are scatter radiation. It is the direct interaction or photoelectric effect and Bremsstrahlung effect that we look at in creating data for medical images. Remember that in dealing with this topic of radiation safety, this presentation presents topics that have some theoretical considerations which have been greatly simplified. This is especially true of the concept in physics. The technical aspects of imaging, which have been greatly simplified here, only serve to facilitate the understanding of the digital imaging process. The aim here is not in-depth technical expertise, but the understanding of key concepts related to ionizing radiation exposure. All imaging modalities emit and acquire analog signals from the interaction of energy with tissue, which are used to create images. Image quality depends only on the intrinsic or objective physical characteristics of an imaging system and can be measured independently by the observer. Image quality is whatever the observer says it is. It is a subjective perception of the image, or as we often say, beauty is in the eye of the beholder. Image quality is defined by an observer's ability to achieve an acceptable level of performance for a specified task. Today, all forms of images are included in medical imaging, whether an MRI or a photograph or a diagnostic X-ray. A digital image is not an exact picture of reality. It is only a discrete approximation based upon the data capture and the software construction of the energy interaction at a specific time with a specific tissue. The modality used and the exposure technique and the region of interest demonstrated determine the data that is captured. How the data is displayed and manipulated or imaged depends on the information requested by the viewer. The same data can be reviewed many times and displayed in many different formats. The process of capturing the data, understanding the data, and manipulating the data to create an image is different for each modality. Digital medical imaging is indirect and often counterintuitive. Image visualization refers to all types of manipulation of the captured data matrix resulting in an optimized output of the image. In other words, we select what we want to see. A software routine that changes the appearance of an image or part of an image by altering the pixels of the matrix of the acquired data is how we manipulate the data in the image. Filters are used to increase brightness and contrast as well as to aid or add a wide variety of viewing enhancements. Before we progress, let's take a look at some of the learning objectives for this section of the presentation. What are the federal and state entities responsible for low-dose medical imaging using ionizing radiation? What is the difference between ionizing radiation and non-ionizing radiation? What is the difference between low-dose and high-dose ionizing radiation? Which type of ionizing radiation can be biologically damaging? What is the difference between patient dose and occupational dose of ionizing radiation? Explain what risk versus benefits means. Discuss the role of probability when referring to ordering patient exams and safety. Explain how ionizing radiation may cause biological damage or cancer. How is dose for radiation monitoring of patients and occupational workers recorded? Relate the details of a traditional radiation safety program. Explain the exposure risk for patients and occupational workers associated with exposure to ionizing radiation. Discuss the role of dose when comparing low-dose and high-dose ionizing radiation. Compare the risk for patients and occupational staff and the threat of being exposed to ionizing radiation. And finally, relate the purpose of time, distance, and shielding in the protection from ionizing radiation. Who is actually responsible, either the federal government or state agency, regarding the use of occupational radiation and occupational radiation protection in the United States? It would appear that it should be standardized. But is it? Briefly, the Nuclear Regulatory Commission, NRC, regulates exposure to radioactive materials. OSHA requires employers to protect workers from exposure to ionizing radiation sources that are not regulated by the NRC or other federal agencies, such as equipment, some accelerators, incidental accelerator-produced radioactive materials, ion implanters, and some naturally occurring radioactive material. States also regulate exposure to ionizing radiation in conjunction with the NRC. The NRC has 28 states which are known as agreement states, and they basically are regulating the ionizing radiation exposures under the auspices of the NRC. These states may also regulate occupational radiation exposures that the NRC does not. The difference is that each state has its own policies and procedures and regulations. And these policies and procedures and regulations, at the minimum, must reflect the policies and procedures of regulations expected by the Nuclear Regulatory Commission, but not limited to those. Each state can have more stringent policies and procedures towards occupational radiation protection control, and if you are creating a worker safety program, you need to understand what the parameters are in your state for occupational radiation safety protection. We have 50 states and a number of territories. Most states have a radiation control agency responsible for regulating radiation-producing machines, and, if also an NRC agreement state, radioactive materials. Some states regulate occupational exposure to ionizing radiation, in part through licensing and certification of medical imaging and radiation therapy professionals. Some states may also limit worker exposure to radiation differently than OSHA. For example, many states and the Department of Energy and the NRC have cumulated annual dose limits that differ. State plans are required to have standards that are at least effective as those of the federal agency NRC and OSHA. The bottom line is that there is actually minimal regulation for the use of ionizing radiation in the United States that is standardized. OSHA is the federal agency for the Occupational Safety and Health Administration that covers ionizing radiation. OSHA standards cover all workers in the private sector as well as employees of most federal entities. State and local government employees are covered if they are in one of the 28 states and 2 territories that operate their own OSHA-approved state plans. The federal government exempts some workers, such as military employees, from having to adhere to the standards of the NRC and OSHA. One of my favorite sayings relates to theory and reality. The saying is simply that in theory, theory and reality are the same, but in reality, they are not. This saying is especially apropos when talking about radiation safety and how and why we utilize radiation or ionizing radiation in the medical industry. In theory, ionizing radiation should be standardized, the use of ionizing radiation should be standardized, and the licensure of people that utilize equipment that creates ionizing radiation should be standardized. In reality, they are not standardized. In most cases, the benefits of indicated medical imaging will outweigh the relatively small excess cancer risk associated with the procedure. Patient management should not be altered based on radiation risk. However, for certain subsets of patients, radiation risk should be of greater concern to the clinician. Damage from low-dose ionizing radiation should be taken into consideration, and you need to look at the probability or the measure of the likelihood of an event occurring which can damage tissue or even cause cancer. Many events cannot be predicted with total certainty. We can predict only the chance of an event occurring and how likely that chance is of happening. The chance of radiation damage from low-dose ionizing radiation damage is very minimal unless we have something like a invasive procedure with fluoroscopy where the physician uses way too much radiation for the procedure. Radiation dose from an imaging study can be reduced by 3 methods. First, one can decide not to perform the study at all. Such a decision should be based on proper understanding of the indications for the study in the first place, review of any previous imaging that might have already answered the question, and an assessment of any special patient considerations that increase or decrease the risk from exposure. Second, an alternative study that does not use ionizing radiation can be selected. And third, the less radiation can be used to create the images. In other words, we can manipulate the exposure factors to utilize the minimum amount of radiation to get the information that we need. The question we'd all like to have answered is, can radiation cause cancer and damage to cells? The answer, unfortunately, is yes and no. Ionizing radiation is a form of radiation that has enough energy to potentially cause damage to DNA, and we can use either high dose or low dose ionizing radiation to create images. So what is the probability of diagnostic imaging energy causing cancer? Well, when we say that the probability of 1 photon of ionizing energy when interacting with human tissue can cause cancer, that statement should be similar to saying there is a probability of a person getting cancer from 1 minute of their lifetime exposure to the ionizing radiation from the sun. Both are theoretically possible, but what is an individual's chance of getting radiation cancer from either of these finite statements? For radiation safety for both patient and occupational workers, we need a proper perspective of what the safety issues are and how to prevent any type of accidents. Here we're going to see how cancer can be caused from ionizing radiation exposure to a cell. But remember, that cell has the ability to repair itself. So this is a probability of an event happening. When ionizing radiation strikes the cell, it excites the atom inside the cell, and it actually ejects energy or an electron from the atom cell. This energy interacts with our DNA, and if it breaks both strands of DNA at the same level, which is a very low probability, we could cause a cancer cell to be created. That cancer cell can grow, of course, over time and may even metastasize. Obviously, large doses of radiation can cause extensive cellular damage and even result in cell death. Remember, if the cell dies, we do not have a cancer created. It is only if the cell mutates. When smaller doses, the person or particular irradiated organ may survive, but the cells are damaged. This increases the chance of cancer. The extent of the damage depends on the total amount of energy absorbed, the time period and dose and rate of exposure, and the particular tissues being exposed. Luckily for us, to counter cellular level mutations, the human body has active repair processes. Although these processes are not entirely error-free, and their relevance to human cancer risk remains unclear. Should a radiation-caused cancer develop on one or more cells, the process may take years and the source of the cancer will be verifiable only in an exceptional case, given the current limited understanding of how cancer develops. Although certain cancers are associated with certain types of mutations, like breast cancer with bone, brain, liver, and lung. Although nearly 1 in 4 persons in the United States dies of cancer from all causes, low-level radiation presumably accounts for a very, very small fraction of these cancers, if any at all. However, the fraction cannot be quantified. The adaptive response systems very efficiently prevent, repair, or remove virtually all DNA alterations caused by the ionizing radiation. It is extremely unlikely that patients or staff will receive any harm from low-dose ionizing radiation. Should traditional radiation safety programs be updated, eliminating outdated data, policy and procedures, and changed to reflect current radiation protection practice and information? The obvious answer is yes. So let's take a look at a traditional radiation safety program. This may cause some concern because after teaching radiology and medical imaging for a number of years, it was the basis for most of our radiation protection, the linear non-threshold dose model. If you take a look currently, the CDC says that this model was flawed and outdated in its use. In other words, this was done during the period of time that the atomic bombs were used in World War II, and we were trying to discourage the use of ionizing radiation or atomic energy, and therefore when these parameters were designed, they were literally flawed to error for safety. The problem with the use of these models over a long period of time is that some of the practices that we have implemented to provide radiation safety actually do just the opposite. And the public and most healthcare professionals are really not aware of the low risk associated with low-dose ionizing radiation and simply think of radiation in terms of dropping the atomic bomb. Take a look at the list of occupations that actually are related to occupational exposure to ionizing radiation to the right. You notice that everything from medical imaging to being a TSA person is included in this list. Everything from being a nuclear physicist and scientist down to being an X-ray tech is included in this list. Go through the list and see what you think about the occupational exposure associated with each of these professions. Now for the part that confuses both healthcare professionals and the public about ionizing radiation, and even is confusing to some occupational workers. There are different environments in which ionizing radiation is used, and different occupations using ionizing radiation. Therefore, we need to have an overall minimum standard based upon the ionizing radiation's effect upon human beings. Just as the measurement of foot and meters is different in the traditional system and the international system, so is the measurement of ionizing radiation. In the traditional system, we use the Rankine, the Rad, the Rem, and the Curie. In the international system, we use a metric system of the sievert, the Gray, and the amount of radiation exposure in air. The real confusion starts when we try to correlate all these different terminologies and integrate all the information so they're standardized. And this, again, causes some problems. Let's take a look at the Occupational Guidelines to demonstrate what I'm talking about. No employer shall possess, use, or transfer sources of ionizing radiation in such a manner as to cause any individual in a restricted area to receive, in any period of 1 calendar quarter from the sources in the employer's possession and control, a dose in excess of the following limits. Whole body dose, which is the head, trunk, and active blood-forming organs of the lens of the eyes or gonads, 1.25 rem per quarter. Hands and forearm, feet, and ankles would be 18.75 rem per quarter. Skin of the whole body is 7.5 rems per quarter. In simple terms, different tissues have different radiation sensitivity. The more sensitive the tissue, the less radiation the occupational worker can receive in that area. We usually divide it out by whole body, hands and forearms, and the skin. We'll talk in more detail about the term REM in the next following slides. An employer may permit an individual in a restricted area to receive doses to the whole body greater than those permitted above, so long as they're during any calendar quarter. The dose to the whole body shall not exceed 3 rems. And the dose to the whole body shall not exceed 5 times the patient's age minus 18 times the number of rems. No employer shall permit any employee under 18 years of age to receive any period of 1 calendar quarter a dose in excess of 10% of the limits specified in the bulletin points above. So what we're looking at is there's a total difference between working in a nuclear radiation plant, medical imaging, and working with mining of radioactive materials. And to that end, there are different standards. The occupational dose is very difficult to understand if you take a look at it as a whole. When we talk about the occupational dose for medical imaging, which is low dose, we can pretty much say that we are looking at a total of 50 millisieverts per year whole body radiation as a limit. Medical exposure differs from occupational and public exposure in that persons, primarily patients, are deliberately and knowingly exposed to radiation for their benefit. In medical exposure, applying a dose limit is inappropriate, as it may limit the benefit for the patient. Consequently, only 2 of the radiation protection principles apply: justification and optimization. An easy way to look at this is that if you're getting radiation therapy to cure your cancer, you're going to get a larger dose than if you're getting an X-ray of your chest to see if you might have cancer. Often the most difficult aspect of obtaining an X-ray imaging study is convincing people that the study is warranted and that the risk outweighs the benefits, because we focus on the risks of ionizing radiations and not the positive that is resulting from the examination. Here's a practical example of risk versus benefits. Here we have a child that needs a CT scan prior to surgery. we will see that if 1 million children get CT scans, there is a possibility that 100 will have a risk of getting cancer. That is simply a possibility. That does not mean that all 100 of them get cancer. But this is what the person usually looks at. They don't look at the aspect saying, if we don't say that 1 million kids receive CT scans, half of them will avoid unnecessary surgery. 100,000 of them will receive surgery that is better because a surgeon is guided by the CT results, and 300,000 of them won't have to go to the hospital for unnecessary surgery. Big difference in what we perceive and reality. We'll now concentrate on radiation safety from the perspective of diagnostic medical imaging. Medical imaging can use radiation to create medical images. Radiation can be divided into two categories: ionizing radiation and non-ionizing radiation. When we look at this, we think of radiation as being energy. So we're looking at the energy which cannot ionize an atom. This is non-ionizing radiation, and radiation whose energy is so high that it can ionize an atom. When it ionizes an atom, it changes the structure temporarily, and this can result in a mutation. We also need to look at the perspective of low dose versus high dose ionizing radiation. Obviously, the more radiation you receive, the higher the probability that there will be damage. And the lower the dose you receive, the probability is that the exam is totally safe. Ionization is energy that is in the form of a particle or a wave. Non-ionizing radiation is in the wave form only. Take a moment to look at this diagram of ionizing and non-ionizing radiation, and then we will continue. We'll now look at the electromagnetic wavelengths of the electromagnetic spectrum and particles that comprise ionizing radiation and non-ionizing radiation. Part of the electromagnetic spectrum are radio waves, microwaves, infrared, visible light, ultraviolet. Ultraviolet is also part of the ionizing radiation level of wavelength. So when we're looking at this, we're looking at the difference in the frequency or the wavelength. In the ionizing radiation, we have the ultraviolet, X-ray, gamma ray for wavelengths, and for particles we have the alpha, the beta, and the neutron particle, which are all ionizing radiation. As we discussed, there is ionizing radiation and non-ionizing radiation, and radiation is around us continually and always will be. Radiation is energy moving through space as either waves or particles. Waves move in patterns like those in the electromagnetic spectrum, which is a wavelength and a frequency, and they also move for ionization with particles. Particles travel more slowly than waves, but they still travel very fast. Examples of particles are alpha particles and beta particles. Radiation comes in the form of radiation waves and particles. In ionizing radiation, we have particles and wavelengths. Let's talk about the electromagnetic spectrum. The electromagnetic spectrum contains wavelengths which are either non-ionizing because the energy or the frequency is lower, it will not ionize an atom, And then as the frequency gets more intense or higher, we actually do have ionizing radiation. We use both ionizing and non-ionizing radiation when we do medical imaging. Non-ionizing radiation is generally considered harmless, and if used appropriately will cause no damage to the patient. If used inappropriately, we can actually cause tissues to heat and cause some damage to the patient. Such as in MRI, we can raise the core body temperature of the patient, or in other exams where we're using infrared or microwaves, we can heat the body tissues, which could even result in blindness. But the parameters we have set for imaging are such that these are usually harmless. The one that we actually focus on is ionizing radiation, because this is the one type of radiation in this electromagnetic spectrum that has the possibility of being harmful. Not that it is harmful, but it has the possibility that it is harmful because it can ionize an atom. Ionizing atoms can cause biological harm to the body and even cancer. Take a moment to look at the electromagnetic wavelength and see the different types of wavelengths and what their uses and harms can be. Diagnostic imaging process, we require a radiation protection program. Developing and implementing a radiation protection program is a best practice for protecting workers from ionizing radiation. A radiation protection program is usually managed by a qualified expert, such as a healthcare physicist or a radiologist, who is often called a radiation safety officer, or RSO. Another best practice in a radiation protection program is designating a radiation safety committee, which includes the RSO, a management representative, and workers who work with the radiation producing equipment, radiation sources, or radioactive materials. Let's take a moment to review the components of a traditional radiation safety program. Let's take a look at the qualified staff. This would be consistent with having a radiation safety officer who is a health physicist to provide oversight and responsibility for radiation protection policies and procedures. The traditional program has a radiation safety officer included in its committee. ALARA stands for as low as reasonably achievable, and it is a guiding principle in radiation protection. We want to eliminate radiation doses that have no direct benefit to the worker or the patient. The traditional radiation safety program includes dosimetry, in which personal exposure monitoring is conducted as required by federal or state regulation for external dose and as needed for internal dose to ionizing radiation. It is sensible only to monitor those people that require monitoring and not monitor everyone who comes in contact with radiation, period. You want to monitor occupational workers. People that occasionally come in contact with radiation, such as a transporter or a nurse in the surgery department, may or may not need a radiation monitoring device. It depends on the time and the dose that they are being exposed to. Traditional radiation safety programs include surveys and area monitoring to document radiation levels, and this includes the tools required and the monitoring program software. We are looking for contamination with radioactive materials and potential exposure to workers from ionizing radiation procedures. In a traditional radiation safety program, we also need to have radiological controls on radioactive materials, including their entry and exit, the receiving of the materials, inventory control, their storage, and disposal. These policy and procedure records are integral to a good radiation safety program. Education is a key component for a traditional radiation safety program. We have education for our occupationally exposed workers, for our contemporary healthcare workers, and for the public, meaning the patient. When we talk about worker training for occupational workers, the worker training should include radiation protection, including the effects associated with ionizing radiation dose, and radiation protection procedures and controls to minimize dose and prevent contamination from ionizing radiation to both workers and the public. The primary three means of radiation protection from ionizing radiation are time, distance, and shielding. We need to know the amount of time you were exposed, how far you were away from the source, and was there any shielding between you and the source. Emergency procedures to identify and respond to radiological emergency situations are required for OSHA. Documentation or record-keeping and reporting programs are essential to a radiation safety program. We need record-keeping to maintain all records and provide reports and notifications as required by federal or state regulations. Each radiation program for radiation safety requires a minimum of one audit annually. Annually audit all aspects of the radiation protection program to update and incorporate new policies and procedures and eliminate policies and procedures that are no longer germane. Parameters for a radiation safety program can be found from publications from the Nuclear Regulatory Commission, which regulates radiation protection programs, and also from your state regulations that apply to such programs. Not only do we look to the federal and state agencies for regulation, we also look to the Atomic Energy Agency or International Atomic Energy Agency to provide guidance for medical exposure and application to exposures for both public and occupational persons. We need to be able to justify these and optimize our practices. The sources of ionizing radiation exposure include radioactive materials and radiation generating machines. As we have discussed, we use many types of radiation in medical imaging, including electromagnetic radiation and nuclear radiation. This image describes the different types of radiation that we use in medical imaging. It describes both electromagnetic waves and particle beams. Take a look at the descriptions and definitions of the use of ionizing and non-ionizing radiation that is applicable with particle beams or electromagnetic waves. Nuclear medicine uses gamma rays, a form of ionizing radiation like X-rays. These are emitted from a wide variety of radiopharmaceuticals to create images of the entire body, from head to toe. The primary difference between radiation or ionizing radiation from X-ray and gamma ray is that X-rays are mechanically generated and enter the patients, while gamma rays result from a decay of a radioactive source and are emitted from the patient. Nuclear medicine studies use radioisotopes in minimal quantities with radiation exposure as low as or even less than a normal X-ray. In most scans, nuclear medicine procedures make a motion picture of the organ or a picture over time and determine the function and functional reserve of an organ. PPE for occupational workers doing nuclear medicine studies differs from PPE for workers doing diagnostic X-ray imaging. Since the patient emits the radiation, all of the radiation for nuclear medicine is in the patient and absorbed by the patient, and only a small fraction is emitted. Therefore, the nuclear medicine technologist does not need to wear any protective PPE from exposure to the patient. Simply, distance will do the trick. There is PPE in the sense that we have shielding for nuclear medicine. We shield the radioisotopes when they're in storage, and we shield the syringes or the other isotopes prior to having them enter the patient. Here we can see a syringe with a shield that goes around the syringe to keep the gamma radiation from exposing the hand of the nuclear medicine tech. The radiopharmaceutical is chosen so as to incorporate itself in a normal metabolic cycle of the human body without any disruption of physiology and with minimal or no side effects. These tracers are generally short-lived isotopes linked to chemical compounds which permit specific physiological processes to be scrutinized. In other words, they're tagged with a chemical to go to a specific area. They can be given by injection or inhalation or orally. A distinct advantage of imaging nuclear techniques is that both bone and soft tissue can be imaged very successfully. Nuclear medicine imaging procedures are very safe and can be used safely even in infants and children, very sick patients, and patients that have advanced renal or coronary disease. The amount of radiation in a conventional nuclear imaging procedure is comparable to that received during a diagnostic X-ray examination. The metabolic or physiological properties of radio-labeled drugs are used to obtain medical information, and the radiation from sealed sources are used in diagnostic devices to image body parts or determine tissue densities. In other words, we're looking at physiology. Remember, the patient is emitting a radioactive decaying signal. How long do those signals last? It depends on the half-life of the radioisotope that's being used. Majority of the isotopes used in diagnostic nuclear medicine are technetium-99m base, and they last for 4 or 5 days after the test. They're excreted by the body. Fluorine, which is used for positron emission tomography, is chosen because it has a longer half-life. About 1 day after a test is over, the fluorine is totally out of the system. A myocardial blood flow can use either technetium-99 or thallium, and these may remain detectable for 30 days. Another PET test uses gallium-68, which again is gone after 1 day. Nuclear radiation refers to the particles and photons emitted during reactions that involve the nucleus of an atom. Nuclear radiation is also known as ionizing radiation. We need to know the source of the radiation, the strength of the radiation, and what type of shielding would be appropriate to minimize the impact of the radiation. This slide demonstrates 5 types of ionizing radiation: alpha particles, beta particles, positrons, gamma rays, and X-rays. It also demonstrates the penetrating power of each and the shielding required. Comparison of deterministic and stochastic health effects. What are these health effects? Deterministic sounds like the word determined, and you're right. Basically, what we're looking at is that when we use ionizing radiation, we can determine what will happen with a certain amount of radiation applied. Deterministic effects generally have a threshold dose below which the effect does not occur. So until it reaches that threshold, there is no possibility of the damage occurring to the tissue. Above that threshold, there is a possibility of the damage occurring, and we know specifically what type of damage occurs at what intensity or threshold levels, which would be like radiation sickness, hair loss, etc. The greater the dose, the greater the severity of the effect. Conversely, if the ionizing radiation is below that dose threshold, the effect will not occur. Now, let's go to stochastic. Totally different. Stochastic effects are assumed to have no threshold dose. So when we talk about ionization of tissue, what we're looking at, there is no threshold dose associated with stochastic effects. Either they will happen or they will not. So previously we used the word determined for deterministic. Let's use the word probability for stochastic. So when we talk about stochastic, we're talking about the probability of something happening. Either it will happen or it will not. Take a moment to read this chart and look at the probability of developing these health effects and the severity of the health effects using ionizing radiation and alpha particles. There are a number of major theories or models about dose and ionizing radiation exposure. Here we can see 5 models looking at the dose and the relative risk of exposure of radiation to tissue. The 3 major theories or models are the linear no threshold dose, the threshold dose, and the hormetic threshold dose. Let's take a look at these. The linear no threshold dose was formulated in 1946 in response to the atomic bomb. Basically, at that time, we didn't have the instruments to measure accurately, but we could extrapolate that no amount of radiation could be safe. And unfortunately, that linear no threshold dose theory is still used today. The threshold model states that at different intensities or different amounts or dose, there is an effect. The effect increases in severity with the incremental increase of radiation. So therefore we know if we get X amount of radiation, we could have hair loss, or we could have X amount of radiation could give us erythema, skin burn, or X amount of radiation could give us cancer. What we're looking at is not that it will give us cancer or skin burn or hair loss, but we know at that threshold it can give us cancer, burning of the skin, and hair loss. There are a number of different thresholds within this specific model, obviously. The Hormetic model is basically the same as the threshold model, except in the threshold model, what we say is there is no possibility of any damage being done to tissue at 100 millisieverts or less. And in the Hormetic model, we say actually some radiation dose is good for you, and we feel that that threshold should be 150 millisieverts. So basically we're saying with the Hormetic model, anything below 100 millisieverts and 150 millisieverts of exposure, nothing is going to happen to the tissue. With the linear no threshold dose, any amount of radiation, even 1 photon of energy interacting with 1 atom, could cause biological damage. It is unfortunate that the linear no threshold dose model is still being used today. We have many scientific studies to debunk the linear no threshold dose model based on the fact that we now have the technology and the information to measure smaller and smaller and smaller interactions of ionizing radiation with tissue. And we have found that below 100 millisieverts, there is absolutely no effect of ionizing radiation on tissue. Acute ionizing radiation exposure. Acute exposure overwhelms the body's natural ability to repair damage from ionizing radiation. Everything we know about radiation suggests that if you get a specific amount of radiation, ionizing radiation, at one time, it is more serious than if you get the same amount of radiation over a long time. So the idea being here is, let's take the old sunburn, suntan. When you get an acute dose of radiation, you get a sunburn, but if you only go out 5 minutes a day, you're still going to get exposed to the 2 or 3 hours total of radiation that you spent getting the sunburn, but the 5 minutes you spend each day will not result in a sunburn. That is what we talk about when we talk about acute ionizing radiation exposure. Exposure of a dose all at one time. Some things are clear. A radiation dose of 500 millisieverts using the linear threshold model is the threshold for the symptoms of radiation poisoning. Using different models, we can assume or extrapolate what may happen with the ionizing radiation exposure. So how are radiation workers and occupational workers saved? Well, realistically, what we look at now is that for occupational workers, you can receive 50 millisieverts of dose for 1 year's exposure to radiation. And we know that less than 150 millisieverts for the Hormetic model and 100 millisieverts for the threshold model of exposure, there is no biological damage to tissue. There is only the possibility of biological damage once you hit the thresholds. The more intense the amount of radiation, or the larger the amount of radiation, the more probability of damage. Nuclear radiation refers to the particles and photons emitted during the reactions that involve the nucleus of an atom. Nuclear radiation is also known as ionizing radiation. In diagnostic medical imaging, we use both ionizing and non-ionizing radiation to create images. The difference being that the energy from ionizing radiation has the potential to cause biological damage. The energy excites the atom, and the atom emits an electron from one of its valence shells. This electron goes on to interact with nearby atoms and electrons. Therefore, there is a possibility of biological damage being done, even up to the point of creating a cancer. Radiophobia is the irrational fear of radiation. It is due to the lack of knowledge about radiation and has had a harmful impact upon the practice of medical imaging using ionizing radiation. The general public and many healthcare workers who are not associated with medical imaging or ionizing radiation have a fear of the interaction of radiation, or radiophobia. Radiation is not to be feared, but it must command your respect. In other words, knowledge of the benefits, or risk versus benefits, is good. When we have radiophobia, we might pass up on the opportunity to get an examination using ionizing radiation that can be helpful. Very simply, you might get a chest x-ray that finds an early cancer that can be cured, as opposed to worrying about getting cancer from the chest x-ray or abdomen x-ray that you're about to receive, and not getting the x-ray and having the radiation not occur, but the cancer was there and the cancer is growing. And now you do not find out about the cancer until it's too late to do anything about it. So you can see that knowledge is power, and fear causes lots of problems in the practice of medical imaging. Misinformation about ionizing radiation has become a major problem. We have had many marketing campaigns about radiation, and we market to the public ALARA, as low as reasonably achievable, image wisely, image gently. All of this is saying that any radiation can be harmful. It is not what we are trying to promote. We are trying to promote the minimum amount of radiation to do the job correctly. If we promote radiophobia, all of a sudden we can get practices that are done in getting the exam to relieve the patient's fear, but causing the patient to get more radiation than they would have without the practice. Once a person has an emotional fear of something, it is difficult, if not impossible, to sway them from their misguided belief with any amount of science, data, or logic. So again, radiophobia, which we talked about earlier, has really been propagated by the healthcare community. A good example is everyone in the public, general public, knows from advertising that 1 in 8 women will get breast cancer in their lifetime, which is true, except the table where they got it from says 1 in 8 women will get breast cancer in their lifetime if all women live to the age of 85. And it does not say that 1 in 8 women will die from breast cancer. It simply states that you would get breast cancer if all women live to the age of 85. Two different conclusions. This is why information is very important in a radiation safety program. Let's take a look at what everybody fears about radiation and receiving a dose of radiation. Very simply, the fear is that ionizing radiation interacts with cells, and it can cause damage to the cells or genetic material. If the cells do not properly repair the damage, it will result in the death of the cell or potentially changes in the DNA, mutations, which can be cancerous. So let's take a look at this logically. I have ionizing radiation that's interacting with my body tissue. Those interactions will be repaired by my body. If the interactions are not repaired, the major probability is that those cells that were damaged will die. They will not replicate, so we have no problem there. The very small probability is that the cells will actually be damaged and mutate. And with these mutations, we're looking at something called cancer. And this happens, but over what period of time, etc. So realistically, we're looking at what can happen as opposed to what really happens and what will happen. Health effects from radiation doses can be grouped into two categories, as we talked about earlier, deterministic and stochastic. Deterministic means that we know with X amount of radiation, this is the outcome. With stochastic, it just says, with this amount of radiation, you could have a problem or you may not have a problem. It's either black or white. You did have a problem or you did not. It doesn't give us a percentage. It doesn't give us an outcome. A true understanding of the physics of ionizing radiation will help the occupational exposed worker to do a better job and also to educate their patients better. When you look at it, medical imaging using ionizing radiation exposure is actually pretty safe as long as it's done correctly. A widely used figure is that a 5% excess risk of death from cancer occurs with 1 sievert of radiation dose. Remember, dose is the amount of radiation that we get at one time. Or acute dose is the amount of radiation we get at one time. We may get several different doses that add up to 1,000 millisieverts over a period of time. Anyway, 1,000, that's a pretty good number, isn't it? So what we're looking at is, as we talked about earlier, if I have a population exposed to ionizing radiation, which will be beneficial to the outcome of their health problem, I can only up the probability by 5%, their chance of getting cancer, period, based upon the fact that they have been exposed to 1 sievert of radiation, which is 1,000 millisieverts. How much radiation is that? Well, let's see. As an occupationally exposed worker, what is the maximum dose that you can get per year? 50 millisieverts. We'll see in an upcoming slide how much radiation we do get, because we do know from each one of the exposures that we utilize in medical imaging. Basically, we used to use the term RAD, meaning radiation absorbed dose. Today, we now use the term gray, which is the absorbed dose that we get under the Systems International or the metric system as compared to the traditional system, and 100 grays equals 1 rad. Well, that's the absorbed dose, but there's also a difference between rad and rem, radiation equivalent in man. The rem, radiation equivalent in man, is also known as the sievert in the metric system. And it takes 100 sieverts to equal 1 rem. The rem is what we use to actually express biological impact. So, there's a difference between the dose we receive and the impact of the dose we receive. These types of radiations are measured and have equivalencies. Take a look at the chart to the right and you can see the equivalent dose. When we discuss radiation exposure and ionizing radiation exposure to patients, we're often talking apples and oranges and different terms and different sizes or doses. What are we saying? Well, today we quantify the amount of radiation that we get from an exposure in coulombs per kilogram, which we used to quantify as a Rinkin. We quantify the absorbed dose of the ionizing radiation as a gray. We used to call that absorbed dose rad. We talk about the biological effect as sievert, but we used to call it the rem. Now, if we take the thing that is exactly the same, the sievert and the rem, or the rad and the gray, is there a difference? Well, no, there's no difference in what they are. There is a difference in how much they are. Because in the metric system, it takes 100 of the sieverts or gray to equal 1 rem or 1 rad. The metric system is far more precise because the measurements are much smaller. Well, that sounds good, but how big is big and how small is small? Well, here's an idea. Take a look at the chart that we have here and the different things that are associated with it. And we're talking about the biological effect, or sievert or millisievert, and we are comparing it to different activities. If I eat a banana, I have 0.0001 millisieverts of ionizing radiation that I'm getting from that banana. Remember, ionizing radiation is all around us and even in us, because we do have potassium and other chemicals within our body. If I live 30 miles away from a nuclear plant, and in 1 year, how much radiation would I get from it? Let's see, 0.000009 millisieverts. Not a whole lot, huh? Well, let's look at something we're probably more familiar with. What would a chest CT scan? How much radiation would a patient get on average from a chest CT scan? Well, that's 5.8 millisieverts. How much radiation is that really? Well, if we compare it to the average natural background dose, in other words, the radiation we get from just walking outside we get 3.65 millisieverts per year. And with a chest x-ray scan, we get 5.8 millisieverts. Not a whole lot there, do you think? Now, if we did a whole body CT scan, we get 20 millisieverts. And the annual dose from the radiation on Monzonite Beach in Brazil is 175 millisieverts. So what we do is we try to take a look at what really exists. I mean, you're talking about the idea that eating a banana is exposing you to ionizing radiation. Are you going to stop eating bananas? Going outside and even inside, you're going to be exposed to ionizing radiation. Where are you going? There's ionizing radiation within our own system, within our own body. What are we going to do about that? So it's just able to define what is the actual terminology we're using and what does it relate to. So if we take a look again, we can take a chest x-ray is 0.02 millisieverts of radiation, which is about half the amount of radiation that you would get in a 5-hour airplane flight. Again, terminology and understanding and really putting things in perspective makes a difference when you're talking about radiation protection. So let me not be a victim of my own ranting and raving on misinformation. Let's be very precise. The sievert is what we use to calculate the biological effect of radiation dose from ionizing radiation. In radiation protection, the sievert is a derived unit of equivalent dose and effective dose. The sievert represents the equivalent biological effect of the deposit of 1 joule of gamma X-ray energy in a kilogram of human tissue. The unit of sievert is important because in radiation protection, it is the baseline we use to quantify the measurement of the exposure. How many patients actually receive more than 100 millisieverts of ionizing radiation in an acute dose or within a very short period of time during medical imaging? Occupational workers practice radiation safety and have protective equipment that they wear during the exam. So we'll look at patients. Patients, even those patients that have multiple high-dose examinations within a short period of time, rarely, if ever, exceed 100 millisieverts of radiation exposure. The greatest exposure patients will receive is usually from nuclear cardiology, a high-dose CT examination, or complex examinations for cardiology and interventional imaging using fluoroscopy. It is extremely rare for a patient to receive more than 100 millisieverts of dose during these examinations in a short period of time. Remember, 100 millisieverts is the base or threshold for the probability of a radiation-induced cancer. It does not mean that we will have a radiation-induced cancer, but only the probability. Medical imaging, on the whole, even with multiple high-dose examinations, does not put the patient at risk with doses above 100 millisieverts in an acute dose or even multiple exams of high dose. At a range of below 10 millisieverts, which is a dose range for most medical imaging and CT studies, there is no evidence of an increased risk for cancer. It takes 100 millisieverts as a threshold dose to have a probability of a radiation-induced cancer, as we discussed earlier. The three primary methods of protecting patients and occupational workers from ionizing radiation deal with the amount of time spent near the resource, the distance from the radiation resource, and the type of shielding being used during the examination. Occupational workers generally receive very little, if any, ionizing radiation. The occupational worker works from a protected area or a control booth that limits the amount of radiation exposure that can occur. Consistent with the hierarchy of controls, PPE or lead vests and eyeglasses should only be used when appropriate engineering controls or administrative controls are infeasible. To make this very simple, the only time you really need to wear protective gear is when you're doing fluoroscopy or portable examinations, because you are not in a protective control area. This concludes the presentation of information for Section 1 of this program. We'll follow with some of the ideas or some of the concepts that you should have learned in this section prior to going on to Section 2 or the end of the program. Let's review some facts related to this first section of the program about medical imaging using low-dose ionizing radiation. There are numerous sources of regulation for ionizing radiation at the federal and state level in the United States and also at the international level. The information may differ between each regulatory agency. Radiation is formed in waves or particles. Radiation is energy moving through space. When talking about radiation used in low-dose medical imaging, there are basically two types of radiation that we look at. One is ionizing and one is non-ionizing. The non-ionizing radiation is considered harmless, and the ionizing radiation has the potential to do biological damage. We not only look at the two types of radiation that's used, but we look at the source of the radiation and the intensity of the radiation and the distance from the source. Or we look at the exposure and how that exposure is applied to the patient. The concept of dose is based upon time of exposure and strength of exposure. This concept is meaningful in ionizing radiation, as ionizing radiation can be harmful. When talking about radiation and ionizing radiation, when we talk about ionizing radiation, we need to make sure that we understand that it can be harmful to the cells or tissues that it interacts with. It does not necessarily mean that it will be harmful or there will be a biological effect. The greater the amount of radiation used and the higher the signal strength, the more probability of a biological effect happening to the patient. In most cases, the benefits of indicated medical imaging will far outweigh the relatively small excess cancer risk, and patient management should not be altered based upon radiation risk. Data provides clear evidence of radiation-induced cancer begins at doses above 100 millisieverts. A cumulative 1,000 millisieverts, or 1 sievert, would have the probability of causing a fatal cancer many years later in 5 out of every 100 persons exposed to this cumulative dose. So we're looking at an extra 5% of all patients exposed would possibly have an induced cancer. In relationship to that, we look at the maximum yearly permissible dose for an occupationally exposed worker to ionizing radiation is 50 millisieverts. This is far less than the cumulative dose of 1,000 millisieverts. The next section will cover radiation protection equipment or personal protective equipment that is outlined in the OSHA regulations. Okay, it's time for a break, time to get up and stretch, and then we'll resume in a moment with part 2 of this presentation.